morning, everyone. COVID-19 has spread worldwide with substantial consequences for public health. Information regarding neonatal outcomes is scarce, and optimal management of the mother and the neonate is still evolving. Let us now try and understand how does one optimize care for the neonates during this pandemic. We shall first look at the general flow. That is, how does one approach a neonate born to a mother who is suspected or a neonate is suspected with COVID-19. We shall understand the basic do's and don'ts of neonatal resuscitation. We shall understand the management of stable and sick neonates and finally address the issue of testing. Thereafter, we shall learn about discharge policy and discontinuation of isolation. Look at this algorithm, starting with an admitted mother or a baby suspected with COVID-19. Note that there are three flows from here. First, isolate this mother-baby dyad. Second, test for both the mother and the baby. And third, care for all the exposed dyads who are to be isolated together in the same area and no admission has to be done in that area. This cycle may take 6 to 12 hours. Mother who are suspected or confirmed COVID-19 should be nursed in an isolation facility which has a separate entry and a separate exit point. The donning area is at the entry and the doffing area is at the exit. The principles of resuscitation remain the same irrespective of the mode of delivery. Resuscitation corner should be in a separate isolated room, preferably with negative pressure. If it is not possible, then it could be in the same room but at least 6 feet away from the mother with a physical barrier like a curtain. A designated member of the neonatal team who is senior should be assigned to attend these deliveries. If anticipated that the baby may require advanced resuscitation, appropriate number of skilled team members who are wearing appropriate personal protective equipment should be present. The World Health Organization recommends delayed cord clamping and skin-to-skin contact to be done in all these neonates. Going on further, positive pressure ventilation during resuscitation can be given using a self-inflating bag and mask or a T-piece resuscitator which has a disposable tubing. In addition, a small viral or bacterial filter is put between the T-piece resuscitator or the anesthesia bag and the mask, or just before the PEEP valve in a self-inflating bag. Remember, this can add significant dead space and hence one should use the smallest available filter and avoid prolonged ventilation using this technique. All disposable parts should be discarded and routine suction is not indicated. During mechanical ventilation, inline suction has to be used and one should avoid endotracheal administration of medications. It is said that plexiglass boxes which have excess portholes, they may potentially minimize the aerosol spread. Drying and standard thermoregulatory measures for preterm baby, that is using the plastic bag, are same as for other deliveries. Bathing is not recommended for obvious reasons. After stabilization at birth, if the baby is stable, shift the baby to the mother's room. If the baby is sick, shift the baby using the same warmer that you used for resuscitation to a designated neonatal isolation facility. The transport team should be same as the resuscitation team and the route through which you go should be a designated COVID doorway. For babies who are stable and they remain with the mother, mother should be encouraged to initiate or continue breastfeeding. Why? This is because the benefits of breastfeeding substantially outweigh the potential risk for transmission. Practice rooming in, including skin-to-skin contact and kangaroo mother care. A healthy willing family member who is asymptomatic may be allowed in the same room to provide help to the mother to support breastfeeding and helping her in taking care of the neonate. While mother and baby are practicing rooming in, mother should perform hand hygiene frequently, including both before and after breastfeeding and before and after touching the baby. Mother always wears a mask while breastfeeding and providing other care to the baby. Surfaces are to be routinely cleaned and disinfected. Sometimes mother may have to express milk, but remember, do it only when indicated and use a dedicated breast pump. If you do not have one, then decontaminate the breast pump as per protocol in your respective unit. The same milk can be fed to the baby and it does not require any pasteurization. Having understood about stable neonates, let us now come to understanding how do we manage symptomatic or sick neonates. They should be managed in a separate isolation facility, separate from your routine NICU. A defined transitional area should be in between. This facility should have single closed rooms. If you do not have single closed rooms, best is to nurse babies in closed incubators. If that is also not available, then place them in radiant warmer in a common isolation ward, but remember, keep a distance of at least 1 meter between these two cots. Also have separate areas for suspected neonates and separate areas for confirmed positive neonates. Negative airborne isolation rooms are preferred for patients who require aerosolization procedures. This includes babies who receive CPAP, babies who receive suction, babies who are undergoing nebulization. If they are not available, one can create such areas by using exhaust fans which drive the air out of the room. These areas should have adequate ventilation and this should not be a part of central air conditioning. The doctors, the nurses and other healthcare professionals taking care of these neonates should be separate from the ones who are working in regular NICU or other newborn care unit. Staff has to be trained in the safe use and disposal of personal protective equipment and should be provided with sufficient supply. In case a separate isolation facility or appropriate care is not available, transfer the neonate immediately using all precautions to the nearest state-designated COVID hospital. Neonates who require respiratory support should be nursed in an incubator, and if the neonate is able to accept enteral feeds, give them expressed breast milk. Note down the details of all healthcare providers who are entering and leaving the isolation facility in a separate register. Specific guidance for respiratory management of COVID-19 in neonates is not yet available since the neonates who were positive, either they required support because of other reasons or they were premature. CPAP and nasal intermittent ventilation is safe, but then again a filter has to be placed in the expiratory limb. Remember, when using these equipments, it should be adequately ventilated room, proper protection measures, careful fit of the interface and addition of a filter. Remember, the area of dispersion in neonates is very low because of low airflow and small tidal volumes. But if that mask or the interface is poorly fitting, this can enhance air leak. There is no clear data on any specific mode of ventilation which decreases aerosol dispersion in these neonates. Specific anti-COVID-19 treatment, including antivirals, chloroquine, hydroxychloroquine, is currently not recommended in symptomatic neonates. In addition, adjunctive therapy like corticosteroids or intravenous immunoglobulin is again not to be given in neonates with suspected or confirmed COVID-19. Let us now understand which neonates are to be tested. Neonates with history of exposure to a COVID-19 positive adult or mother having COVID-19 within 2 weeks or 14 days prior to birth. These neonates have to be tested. Irrespective of the history of exposure, if a neonate presents to the emergency with pneumonia or severe acute respiratory infection which requires hospitalization and there is no other underlying illness, these neonates also have to be tested. The test done is RT-PCR and is done on day 5 after birth or at the time of symptoms. If initially the test is negative or you were not able to do this test, testing should be repeated at 48 hours of age. For asymptomatic neonates whom you expect will be discharged prior to 48 hours from the unit, a single test between 24 to 48 hours can be done. Serological testing is not recommended to diagnose acute infection. The swab used is upper respiratory nasopharyngeal swab for routine sampling, and in ventilated neonates, lower respiratory tract specimen is also sent in addition to above. Clinicians and other healthcare workers who are taking these samples should wear appropriate personal protective equipment. While you are awaiting the test results, what has to be done? Isolate the neonate in a separate isolation room or incubators or rooming in with the mother in case the mother was suspected or positive. For a neonate who is asymptomatic and was suspect to start with and now the tests have turned negative. So, I repeat again, this neonate was tested because it was suspected and baby comes out to be negative. For these neonates, isolation can be discontinued. However, if you were not able to test or you were able to test 96 hours prior to exposure or the baby stay is less than 4 days or equal to 4 days in the hospital, these neonates can be discharged, but remember they should be home isolated for the next 14 days. If the neonate is still admitted, better is to test the neonate and then decide the further plan of management. For a symptomatic neonate, if the symptomatic neonate meets the listed criteria, isolation can be discontinued. If the test is not done, then all the listed clinical criteria have to be met before the isolation is discontinued. Asymptomatic neonate can be discharged early the moment it is feasible and safe, ideally with the mother or with a healthy attendant, followed by home isolation for 14 days since the time of last contact. Symptomatic neonate has to meet the listed criteria, and one option here is to send 2 samples, they turn as negative, and then you discharge this neonate. The other option is, if you do not want to test, then the baby first 3 criteria are met, but the baby is continued on home isolation. If the mother was discharged before being declared infection free, she should be considered infective till she meets the listed clinical criteria. What should the mother do at home? She should wear a medical mask and practice hand hygiene. The healthcare providers should arrange a telephonic follow-up or a home visit by a designated nurse, and at any time if the neonate becomes unwell, he should be taken to the designated hospital facility. Mother practices respiratory hygiene and wears a mask while providing care and breastfeeding a neonate. If the discharged neonate is positive, then the other adults, the uninfected individuals in the house, for example, the grandparents and those with comorbid conditions, should not be assigned to provide care if possible. So, we understood what has to be done and what not has to be done during resuscitation. We understood that stable babies have to be cared for with the mother and rooming in has to be practiced. These babies can be breastfed. We understood when to do testing and what sample has to be sent. We also understood the basic principles of isolation and the precautions to be observed at home. Thank you.